What we should do first is talk to the man.
Okay, we might start off, everybody who's in the room, and welcome everybody who's online. This is the first NCAS Journal Club for 2016, so welcome, and we've got 10 more planned for the year, and we're still hunting for people to present during the year. And in fact, it is called Journal Club, but we want to make the point that it's not just for reviewing and critiquing articles, and I'll show you a live example of that after Laura speaks this morning. So I'd like to welcome Dr. Laura Hardefeldt to present this morning. Laura is at the Vet and Agricultural Science faculty at Melbourne Union. Is one of our PhD students in the animal stream for NCAS. So welcome, Laura.
Thank you very much. So I just chose 3 papers today which I thought would be a good introduction into the veterinary literature around antibiotic use and antibiotic prescribing, and particularly in light of the fact that we've been working quite a lot on developing the VetNaps and trying to work out the best methodology around delivering that, and so I thought it'd be good to look at the methodologies that other people have used. So I chose 3 papers from around the world, and I say recent because they are up there with the most recent papers, but they're not very recent at all. So they're in the last 5 years. So I just thought it'd be good to give a bit of an overview of the literature to start off with. And it's pretty sparse and hard to come by recent literature. But in 2006, Heath did an overview of the industry, and at that time there was 7,510 vets in Australia, 3/4 of which were on the East Coast and 1/4 were in Victoria, and 40% of those were in rural practice. And unfortunately, there's been no census since the 2000 census, but 45% of practitioners were in solo practice at that time, which is probably about what it is now, I would say. But obviously there would be a lot more vets in Australia now. Since 2006, there's been another 2 vet schools open, and so there's a huge number more veterinarians coming out each year. So those numbers are probably out of date. So the aims of this presentation were to present some of the recent veterinary literature on antibiotic use and then to examine the methodologies in these papers. So the first paper is out of the Journal of Small Animal Practice in 2011 by Stark's group on antimicrobial usage in dogs and cats in first opinion vet practice in the UK. So they had a convenient sample of 11 practices, and this was a data mining project. So they downloaded the data from these practices for the whole year of 2007, from the 1st of January to the 31st of December, and they chose these practices. There wasn't a huge amount of information on the paper on how they chose them, but they definitely chose them because they were all using the same computer program to run their practice management software called RxWorks, and I guess they thought that would be the easiest one to mine the data out of. And they looked at the total number of prescriptions and administrations at a practice level. They looked at both topical and systemic antibiotic use, and they did include repeats, and also if the same animal was seen several times for the same disease, they included that as well. So they didn't want to underestimate the number of antibiotics that were being used. And then they also sent out just one questionnaire per practice, looking at the type of practice, if it was referral or general practice, how many vets were there. They had practice standards, so in the UK they have the practices can apply to have a higher practice standard, and they've got to meet some guidelines set out by the Royal Vet College to acquire those standards. If they had antibiotic use protocols and any further qualifications of their staff, and actually quite a lot had further qualifications in their staff. So 3 out of the 11 practices had written antimicrobial use policies, and it's hard to know, there's no information on the general rate of antibiotic protocols in the UK, but I think it probably is quite a lot higher than here. That number surprised me at first because I think when we get the results, we'll probably find that 0 have antibiotic use protocols. Certainly, I just did a bit of a ring around to the practices that I've worked at and where my friends are working, including quite a few of the university hospitals, and some have verbal protocols, but none have written protocols. So, so that kind of surprised me, but I do know that the UK has more written protocols than the US and in Australia. And there was a paper in the US by John Prescott's group, and he found 3 out of all of the teaching hospitals in the US, so about 30 or 40 teaching hospitals in the US had written antimicrobial use policies. So, so this was pretty high, really. So they had 45% dog consults, 33% cat consults that had antibiotics administered, and that's pretty standard. So all of the papers had around about the 40 to 50% of dog consults being prescribed antibiotics for incident events. So 11% of these were topical. Oops. And then they have this statement, so in total 60% and 83% of any systemic antibiotic substance administered or prescribed in dogs and cats respectively were deemed to be critically important antibiotics on the human medicine, and that's using the World Health Organization's list of critically important antibiotics. So those numbers seem pretty scary to me. That's pretty high. I just went and found the WHO's critically important antibiotic list, and unsurprisingly, penicillins are on this list. And so if we go back to the results from this study, beta-lactams made up 75% of dogs and 84% of cats, and then everything else was pretty low. So they were using a lot of penicillins and potentiated penicillins in this study, and the fact that they're on the critically important antibiotic list really dragged up the percentage of animals that made it look kind of bad. So this was.
Could I just ask?
Yeah.
So, drugs like Meropen and penicillin used in veterinary practice?
They are, but in a very small amount. So it's really quite cost prohibitive. So we used high-carcillin in eyes, and sometimes it's used for reproductive work in mares, valuable mares, but certainly in large animal practice, it's horrendously expensive to treat a horse with something like that because of the dosages involved. Even for foals, to put a foal on a drug like that is, hundreds of dollars a day, and so it makes it really difficult on a cost basis, let alone on an ethical basis. So this was the first issue that I came across in all of the papers, is the lists of drugs that are on their critically important antibiotic list. And so the Antimicrobial Resistance Standing Committee and for Australia, they have a critically important antibiotic list as well. And their beta-lactams are listed as low importance on that list, although the potentiated penicillins are medium. So the only ones of those antibiotics that were used in this survey were the fluoroquinolones that made it onto the high list. So, if you use that rating system, then only 5.5% of all the prescriptions would have been rated high on the importance rating. So we'll find with the other papers that this issue is really continues to be a theme throughout the papers. So the other issues with the paper, the sample's not representative. It was only 11 practices. It was a convenient sample, and they, note quite rightly in the discussion that they weren't trying to get a random sample. They were really targeting practices that they'd used in research before that they knew would participate. The issues with data mining that they had were a third of the records had insufficient data to be included in the study, and the lack of standard nomenclature. Even though there is a standard nomenclature, people don't use it, and so they really couldn't make any further investigation into appropriateness, even using the data. Also, the other issue we run into in terms of judging appropriateness is that for most of the diseases we deal with, there's no guidelines on which to base appropriateness of antibiotic use. So the second paper is out of Canada by Scott Weiss and John Prescott's group, and it was published in 2012, again looking at outpatient antibiotic use for new diseases. So they only looked at incident diseases, and they sent a mail out to all the vets in Ontario for an expression of interest. There was about 2,500 vets approached, and they wanted them over a 12-month period to collect data for 1 day a month. And they were randomly assigned to collect data on day 3, 11, 19 or 27. If they happened not to work on that day, they were asked to collect it the following day. But if they just didn't see any patients that got antibiotics that day, then they just didn't collect any data for that day. They collected a maximum of 5 patients. They were only looking at incident diseases, and they looked at non-topical antibiotics only. So they excluded all topical antibiotics in this study. So they collected quite a bit of information, I guess because they were only asked to do it on 5 patients. They didn't feel so bad about making them collect more, but they collected this into a diary, and they got signalment, diagnosis, duration of signs. They asked them for a subjective assessment of the severity of the condition, if they had any pre-existing disease, the diagnostics that were done, and any treatment that was administered. And they looked at the frequency of prescriptions in each body site, and then they also focused on 3 disease conditions. So they only had 84 vets participate in their study, so that's only 3.5% of the vets in Ontario, and only 0.6% of the vets in Canada, so it was a very small sample size. For the antibiotic prescriptions, again, 52% out of the new disease events, the incident disease events, got antibiotics, which is pretty typical, seems like. And if we looked at the common antibiotics for dogs, the first generation cephalosporins and the potentiated amoxicillins for cats were the most frequently prescribed. And this is the type of table that they produced for this, and this is similar to the groups that we're considering for the NAPs. So we've got skin diseases, gastrointestinal diseases, urinary, and so on. And I'm not going to go through this whole thing, but you can see for skin diseases that 67% were treated with cephalexin, and that's in line with the current guidelines. And for gastrointestinal disease, 71% were treated with metronidazole, which I think is fairly typical. So then they also produced this table, and I'm just going to focus on the second bit to start off with. So the importance for use to treat human infections. So in terms of the very high importance, 45%, and for dogs, nearly 80% of antibiotics were in the very high importance category. And when you look to what list they use a different list again. So they used Health Canada's list, and it is different to the WHO and our list as well. But the potentiated penicillins are in the very high importance group. So that's driving that the high number in the classification 1. They also looked at the use in veterinary medicine as first line or second line. And I was interested to know where they got this from, and you had to chase a bit of a paper trail to find it. But this was developed by the Ontario Veterinary College Veterinary Teaching Hospitals Infectious Disease Committee, and published in a paper a few years ago, and they created their own first-line, second-line drugs, and not surprisingly, the penicillins and potentiated penicillins were in their first line of treatment. So if we go back to the previous slide, that 88% and 71% of drugs were within their first line therapy. So then the 3 specific disease conditions they looked at, I'm just going to go over this briefly, but feline upper respiratory tract disease, which is mostly considered to be viral, feline lower urinary tract disease, which is a stress-induced condition in cats, and canine infectious tracheobronchitis, which is kennel cough, which is a bacterial condition but usually is not treated with antibiotics. So they found that these conditions were overtreated with antibiotics, which is fairly typical of most studies that look at these diseases. They also found that bacterial culture sensitivity was only being undertaken in a very minority of cases, and this is fairly typical in veterinary practice as well. So the issues with this study, only 14% of Ontario's population is rural, so the results are definitely skewed towards urban veterinarians. It was voluntary participation, so there'll be bias associated with that. There was a very poor response rate, and yet again we've got another list of critically important antibiotics, so it's hard to compare the results across these studies when the lists of CIAs are varying between the groups. But I did think that maybe we should add severity into the veterinary NAPs. They made some assessments of treatment duration, looking compared to severity of disease, and I thought that was a useful indication to look at why vets might be prescribing antibiotics for longer rather than shorter periods. And then the third paper was antibiotics used most commonly to treat animals in Europe, which appeared in the Vet Record most recently in 2004. So this was a 1-month electronic survey that they conducted in March 2012. They provided the survey in 5 languages, and they promoted it through vet organisations and medicine agencies. So they had some demographic questions, some practice questions, factors and information used to describe on prescribing behaviour, the sensitivity testing, and then the 5 most common reasons that they used antibiotics. And these top 4 were the results for those were published in a different paper in the Vet Record in 2013. So I'm just focusing on the 5 most common reasons. But the methodology was you had to go back to the first paper to find that, but they analysed it at a species level, and they only analysed the species if there was more than 500 responses for that species. If they had enough, then they broke it down further. So for the cattle category, they were able to break it down into cattle and calves. And then they also analysed by indication, antibiotic class, and they did look at the critically important antibiotics versus other antibiotics, and they used the WHO's categorisation in this study. So if we went back to the first paper, this was the responses received per country, and can see that the response rate was pretty poor. Sweden had the best, so they had 13%, but of the top 4 countries with the most vets, apart from France, it was around 1% of respondents. Liechtenstein did well, 18.2%. They've only got 11 vets, so I don't think we can read too much into that. So this was the number of indication antibiotic pairs that they received for each animal species. And the ones in bold were the ones that they were able to analyse because there was more than 500 of them. And then they also produced this messy table, which has their critically important antibiotic classes listed here, and all of these add up to 100. So I'm assuming that all of the antibiotics that were used in this study were on the critically important antibiotic list. But then they produced these tables for every species, and they've got their critically important antibiotics in bold. So for mastitis, only they had 22% were using critically important antibiotics, and the ones in bold over here are only the 3rd and 4th generation cephalosporins, the macrolides, and the fluoroquinolones. So it seems like they've made their own list to me. They just chose the ones that they thought were actually critically important and bolded them up. So, but you can see for respiratory disease, they had 45%. The ones in brackets are for use in calves, so 44% of calves, they were on the critically important list, and that's because fluoroquinolones are labelled for use in respiratory disease in cattle up to joining, so they're about 2 in both the US and the UK. So that's dragged up the number in the critically important antibiotics. So that was for cattle and calves. And in their discussion, they say the responses cannot be used as a quantitative measure of the indication for which antibiotics are most commonly used, nor the relative use of the different antibiotics. So basically they're saying that their results don't mean anything, which is hard when you've got such a low response rate to make any sort of interpretation of the results. And so they say they do provide a broad insight into the different classes of antibiotics that are being used for different indications. And I think that's really all we can take from that paper. So the challenges that we're facing is in terms of our sampling. To try and make it a bit more reliable, it would be great to have a random sample of veterinary practices. Unfortunately, that's not going to happen with us. We are going to get a convenient sample, so we're going to ask the practices that are taking students to participate in the survey. We're still trying to work out how to get a random sample of consults, whether we ask students to collect consults randomly throughout the day, if we send them a text message to say collect the next one, if we ask them to collect for a whole day out of the 2 weeks they're there, and there's issues around how veterinary practices run that would influence that. So I think we'll probably have to do some trial and error, try a few different things and see which works the best and get some feedback from the practices and the students in doing that. So designing the right survey so the input's fast and we get the information we want. So ideally we want the data input to take less than a minute per patient, and that will improve the practices acceptance of it, if it's not taking a huge time between consults for the students to get the information, but if it takes longer than that, then it will delay the consulting procedure throughout the day, and that's going to make it really difficult on an ongoing basis. So we are going to develop an app to allow students to collect the antibiotic use data while they're visiting practices in their final year, and so engaging the students so that we get good quality data, and maybe we'd be better off just targeting 10 or 12 motivated students rather than making it compulsory for the whole year level to collect data, and they're the things we're trying to work out at the moment as well. And then choosing our list of critically important antibiotics, which obviously not a problem right now, but certainly when we come to analysing the data, it will be it'd be nice to be able to compare our results to other countries, and that's going to be challenging looking at the critically important antibiotics. So this is the data we're looking at collecting right now. So we are getting some practice demographics, just the number of vets, the type of practice, that sort of thing. We'll collect an animal ID, the weight of the animal, the age, the species, which we're just focusing on dogs and cats at the moment, which antibiotic or antibiotics were used, the dose, the route, the frequency, the duration of treatment, whether it was for prophylaxis or treatment, and then the indication for antibiotics, which we've changed that from diagnosis to indication for antibiotics. If there is a planned revisit, and then if any samples have been collected for diagnostic tests. And I think we will add in a question about severity as well, because I think that will help in our interpretation of the antibiotics that are used and the duration that they're used for. So that's the end of my talk. Happy to answer any questions.
What proportion say trauma in a is it like 30%?
Well, we're not sure. So we do have a few different categories for trauma. So we've got hit by car, and then we've got dog bite, wounds, or cat bite abscesses. So there are, within the trauma category, but they can just put trauma as well. So, but I think most people, there'll be complicated. When we were at Lord Smith this week, there was a cat that had a fractured jaw, a broken leg, and a diaphragmatic hernia or something, so, but it's, it's trying, what we were trying to get was the primary reason that they put the animal on antibiotics. So which one of those conditions was the reason that the cat went on antibiotics in the first place? So, which is sometimes hard, and it's certainly hard going in retrospectively and talking to somebody who didn't see the animal in the first circumstance. So I think it will be in some ways easier for the students when they're there looking at the patient for the first time with the veterinarian to collect that information than us trying to look at the medical record and say, well, why did they actually put it on antibiotics? So
We discussed this at length before, but I'm here, but how are you judging appropriateness?
So we're not judging appropriateness, and for a few reasons. One of which is that we have no guidelines for most diseases on which to base appropriateness. And then the second reason is that we want practices to participate, and having students discuss appropriateness with the vet at the time might be fairly confrontational. So that might be challenging initially. But also we just have no way of judging appropriateness on a big scale at this stage. So
The plan is to get a lot of lead data.
Yeah.
Distill that eventually into practice guidelines and then to go back and assess it again to see if there's been change.
and there is some there are some ongoing kind of trials to try and get some guidelines up and running for some of the more common conditions as well. So hopefully we'll have some guidelines coming out.
Yeah, guidelines, because you don't have to have guidelines to look comprehensive.
No.
The Bridge Society got a fantastic poster. It says in this practice we use this antibiotic, this thing, this antibiotic, that.
Yep.
And it's just a one page.
Yes.
So, but we don't have antibiograms real on a mass scale to say that 70% of streps are resistant to this, or 100% of streps are sensitive to penicillin. We don't have that information, so it makes it really difficult to make any broad recommendations. So,
and I guess one point is we don't know what rate, and I don't think any of those surveys looked at prophylactic use.
no.
That's one area we need to look at appropriateness. We are asking questions in papers. So
Yeah.
I think that's one easy area to take.
That point you made about antibiograms, where are those isolates going, and how might we get at that sort of information?
So mostly they go to one of two commercial laboratories. So there are some other, like Melbourne Uni has a lab that does some culture sensitivity, but mostly they go to one of two commercial laboratories. So, and they don't publish those antibiograms.
Can I also just follow on, how many, when you see a case, how often do they actually collect a sample?
Yeah.
Is it a common practice?
Well, I would say in general practice, the 4% that they saw in the Canadian study would be about what I would think would happen in Australia as well. It does depend a bit. So in mastitis in cattle, the samples are really cheap to run. It's only about $10 a cow, and it usually costs about $35 to treat a cow with mastitis with antibiotics. So certainly for cows that don't respond initially, or lots of farmers will collect a sample before they start treating and freeze it. So because it's cheap, but for me as an equine vet to submit a sample, it's around $120 just for the lab fees. So so it, when my consult fee is only $90, it's really makes it really expensive for the people. So there's not a lot that goes on for a lot of species. So
Laura, we have got a question here from Deb Friedman.
Yeah, so Deb asked if there's a capacity to expand the survey to vets that care for farm animals, and we are working on some indications lists at the moment for farm animals. So we're going to trial it in small animal practice, and then hopefully we can expand it fairly rapidly into rural practices, to all the practices that the students go to. So I think that should be fairly easy to do once we've got the layout sorted out. So.
I mean, even if you haven't got national guidelines on appropriateness, surely there must be some guidelines that you would say and not use the term appropriateness. You know,
Yep.
it's consistent with this document or.
We wouldn't do it at the point of the survey, Mike. We
No.
would once we get the data.
Once we've got analysis, I think,
Make some assumptions, but at
you know,
the
we
point-
could say that, you know, half of all dairy cows were treated with Ceftiofur for lameness. And I think if anyone read that, they would think, yeah, that's pretty inappropriate, that using a third generation cephalosporin to treat a lame cow. So I don't think we'll need to necessarily say this was inappropriate or this was appropriate. So.
I guess the other reason too is we're asking students to collect the data.
Yeah.
The students find it confrontational to ask the practitioner, and so they feel that in themselves. I'm not sure that we want students necessarily judging appropriate.
Yes, yeah, I can
Yeah.
As
understand
well
that.
as I think we want to collect some data and see what's being used, develop some interventions, and then we can assess appropriateness and give more feedback about appropriateness.
Yeah.
Okay, no more questions? Okay, thanks Laura, that's great. So I'm going to not present any journal articles, but I'm going to present a presentation that I did at the Australian College for Infection Prevention and Control conference last year in November in Hobart. Some of you might not know, but I'm in the final 6 to 7 months of my own PhD, and which is focusing on national surveillance programs for healthcare-associated infections in Australia, of which we don't actually have a national program. And it's involved a number of studies, and this is a presentation on one of the studies that I did, which is a discrete choice experiment. And I apologise for those of you who know what a DCE is, but and so some of this explanation might seem very basic to you, but the audience that I was presenting to would not have heard that term before previously. And I'm happy to say that there is also an animal connection in this talk too, and some of you will have heard of that also. So this is a Prezi presentation, so hopefully nobody will get seasick, but it's about preferences for a national HIA surveillance discrete choice experiment. And what we know from previous studies in Australia of healthcare-associated infection surveillance is that not all states have surveillance programs. Some do, some have very well-established programs. Those that do have programs tend to use different definitions. There's different methodology. One of my studies demonstrated that less than 50% of those people who do surveillance actually do it prospectively, which is the gold standard. A lot of more than half don't risk adjust their infection rates, and so the data that people are being fed is not all that meaningful. And finally, that the data is not always reported to the executive. In fact, only 15% of the occasions people who do ventilator-associated pneumonia surveillance report it to executives. So it brings into question the whole purpose of why people are doing surveillance if they're not reported to people who need to know. With all that variation, clearly there's an inability to collate the data and generate national data because there's such broad variation. Another important finding was that less than half of the people who do surveillance have actually received any training in surveillance. So it's not clear where they get their surveillance knowledge from or how they apply the case definitions, which can be complex on occasion. So we know that data drives infection prevention efforts, and it's also nowadays used to measure hospital performance, and it can trigger financial penalties. In Queensland now, if there is a preventable bloodstream infection reported, the hospital gets fined $12,000. And that's not well known and it's not publicised, and Queensland don't actually publish their hospital infection rates publicly, and it's something that's done quite underhandedly. But it's a common phenomenon in the States and also in the UK. And in fact, there's a lot of support from the UK. Martin Keenan, who spoke at this conference, suggested that it was the financial penalties that actually greatly assisted the driving down of the MRSA rates in the UK hospitals over the past few years. The question is, when it comes to surveillance programs, there are various ways to do it, and what we needed to try and understand is if clearly one size is not going to fit all. Apologies for that image. So the question for this particular study was, what are the preferences and priorities for stakeholders when considering a national HIA surveillance program? And so to answer that question, I undertook a discrete choice experiment. So a discrete choice experiment is a survey method. It's an attribute-based survey method, and it actually provides quantitative information about the strength of people's choices and preferences when they're given options. It's very useful for priority setting, and it's been demonstrated to be useful in areas where there are competing demands for limited resources, which infection prevention is. And it's also able to assist in predicting uptake of new programs with regards to how well people who participate in the program would accept a new program. So the analogy. This is Hugo, and Hugo, as many of you will know, is our 5-year-old Shih Tzu Yorkie who last year ventured the wrong way and was hit by not one but 2 trains, one travelling in the opposite direction, flung him into the other one. And that caused fairly serious trauma. He was a trauma case, hit by a train. In fact, the vets had HBT written on his card, hit by a train. So I got the phone call, and by the time I got to the vets, I was met with a severely traumatised partner who was covered in blood and very tearful, and a traumatised son who had witnessed it all as well. And they were looking at me as if to say, well, what are we going to do? I had an opinion as to what we should do in that situation. But I had to also consider other issues. And so one of the things that we had to, if this was a discrete choice experiment, we had to think about what's important in this situation. Hugo's short-term comfort, his quality of life in the longer term, family happiness was fairly up there, and in the short and long term, and also, of course, the cost. And so if this is a discrete choice experiment, these are what we would call the attributes that we would build into an experiment. So if we did turn into an experiment, this is some of the hypothetical scenario choices that we could make up. So the attributes there on the left-hand side, short-term comfort, quality of life, and happiness and cost. And we would get people to choose whether or not they would prefer to have, for Hugo to have treatment A or treatment B. You can see each of those attributes have different choices. And so I would ask the family, if these were the 2 treatment options for Hugo, which would you choose? And probably not just the family, the whole neighbourhood who knows Hugo, and the dog walkers down at the beach, and everybody else who knows Hugo could participate in this choice experiment. And they would be given a series of choices where the attributes remain the same, but the treatment choices differ. And so through doing this repeatedly over a number of times, and through appropriate data analysis, you can start to understand and quantify which of the attributes are most important to people who are participating in the experiment. So back to the surveillance situation. So to identify the attributes for a surveillance program, I conducted a literature review, and also had a number of semi-structured interviews with leaders from national HIA surveillance programs across the world, and they were extremely generous with their time with those interviews. Also interviewed state program leaders in Australia, and also leaders in national surveillance initiatives across Australia as well. From those, the qualitative analysis of that data, and it sounds simple, but it was actually quite an excruciating process for me, anyhow, qualitative research. We were able to identify a number of the attributes of a surveillance program, and that's then listed on the left-hand side: participation requirements, surveillance protocol, the competency of people involved in the surveillance program, the accuracy of the data, and reporting of the data. From those attributes, we developed different levels. So these were the levels are what you present in the choice, in the hypothetical scenarios. And so for the participation requirements, for example, they could do targeted surveillance for 12 months with a choice of other surveillance for 3 months, or targeted for 3 months and choice of other for 3, or they could have a complete choice of the sort of HIAs that they would do surveillance on. And for reporting, there were 4 choices: public with no financial penalty, etc. So we built this into a discrete choice experiment, and it looked something like this. And this is one of the choice scenarios that were presented in the survey. So the attributes down the left, and they would be provided with a scenario which included a statement: in your current working environment with your existing resources, which surveillance program would you choose for a national program? And they would indicate surveillance program A or surveillance program B. There were 12 choice questions for each participant, and we duplicated one of the questions to check for consistency. We purposefully invited 184 participants to undertake the survey, and generally coordinates infection control programs from larger hospitals and networks, ID physicians attached to infection prevention programs, senior health department employees or advisors whose role influences policy, members of national representative committees, and opinion leaders in infection control who didn't fit any of those above categories, and there was only a few of those. So of the 184, we had 122 completed responses, so a good response rate of 66%. The majority were infection prevention nurses with some ID physicians and also health department representatives. It was an ageing group, which is not surprising, I guess. 76% had more than 10 years experience in infection prevention, and 85% of those who worked in hospitals were from hospitals with more than 200 beds. We had reasonably proportional representation from each of the states and territories. Prior to the DCE, there was a series of attitudinal questions that we asked to just give us a bit more background as to what they thought about surveillance, and the question was, to what degree do you believe the following are beneficial to your infection prevention program? And as you can see there, the majority believe that surveillance is beneficial, national surveillance would be beneficial, the ability to compare data with like hospitals would also be beneficial. Public reporting had pretty strong support, but there was some uncertainty there, and the association of financial penalties for high rates, people were less certain how beneficial that would be to their surveillance programs. So the results. So for the first, and I'm not actually presenting any of the outcome numbers, the data, the figures. I'll just be presenting which options were most preferred. So for the participation requirements, the most preferred option was to do continuous 12 months targeted surveillance with a choice of others for 3 months per year. And interestingly, the least preferred option was to do minimum 3 months surveillance on your own choice. So people want to be told, they want surveillance to be mandated, and they want to be told which infections they should be targeted. But they also want some sort of ability to tailor a program to suit their own needs. Which surveillance protocol? There was 2 surveillance protocols. So there's a light protocol which required fewer resources, and because it collected less data, because which meant you couldn't actually risk adjust the data. But the preference was for the standard protocol, which is currently what exists in most places who do surveillance properly, which requires slightly more resources, but it does, because it includes data for risk adjustment, and it does give you the good ability to compare data. So people want to be able to compare their data with other hospitals. The competency, when it comes to competency, the scenario was there was 3 options. The people who were collecting the surveillance data, they need some sort of competency assessment, and so the example that was given to them was an online assessment. Every time they submit data, they would be given a series of vignettes, and if they get them correct, then they can continue collecting data. If they get them wrong, they need to do some remedial work. So they do that competency assessment every time they submit data, which would be quarterly or an annual assessment or every 2 years. And the most preferred option here was an annual assessment, which supports reasonable consistency. It didn't support the highest consistency of surveillance processes. I'll speak to that shortly. And the other attribute there was about accuracy, because it's a given that you're never going to catch all infections that occur as a result of healthcare. So how accurate is good enough? And they were given 3 options there, and the overall response was that people continue to want very accurate data with only 1 to 5% error range. Interestingly, though, when we split it up by occupation group, it was the clinicians. There was a significant difference, because the clinicians wanted very accurate, but the non-clinicians, the health department people in the hospital, people who weren't involved in the clinical side of things, were happy enough with reasonably accurate data. And that brings up the issue of consistency versus accuracy. I think it's a really interesting topic, because it also touches on the difference between infection definitions, the clinical infection definitions, and epidemiological surveillance definitions. And usually clinicians want the clinical definitions, and the non-clinicians are happy with the epi definitions. And from the semi-structured interviews, one of the specific areas of discussion was this consistency versus accuracy in a surveillance program, and each of the respondents in those semi-structured interviews from programs around the world considered that consistency was much more important than accuracy with HIA data in surveillance networks. When it comes to reporting, there was an overwhelming support for the data to be publicly reported on a website, but not associated with financial penalties. And the least preferred option was publicly reported and for it to be associated with financial penalties. So there's good support there for public reporting of data. And so just on that, it was worth just touching on a few of the issues that public reporting and financial incentives or disincentives can induce. And this is a paper from last year by Harold Horowitz, who reflected on the American experience of public reporting and financial penalties. And he describes a destructive triangulation has arisen between hospital administration, clinicians, and infection control departments, and describes scenarios where hospital administrators are concerned about the hospital's reputation and also about the financial penalties that may incur, and he believes that this leads to pressuring infection control staff to actually revise their HIA data that they report, which clearly puts infection control teams in a difficult situation when they are trying to do the right thing. And Horowitz firmly believes that the financial penalties are a bad thing, and rather than feed the staffing bird, believes that they're probably performing poorly because they're already staffed with resources, and the financial penalties will just make those resources even more limited. So the final results were, just summarising, was preferences for a targeted 12 months of continuous surveillance program with the choice of others for 3 months, a standard protocol to allow for risk adjustment, annual competency assessments to have very accurate data, and public reporting of data with no penalty. So to our understanding, this is the first time a DCE has been used in the infection prevention environment, and certainly for looking at surveillance programs. But I think given the results, it's really provided us a really unique insight into what sort of surveillance program, if Australia ever decides to develop a national program, what sort of shape it could be, and what shape would be acceptable to those who will have most invested in it. And we also believe that the DCE would actually work well for lots of other areas in infection prevention. So I know you're wondering, so back to Hugo. Hugo, we have an extremely fantastic vet, in fact, who we've gotten to know over the years, and he did us a very good deal. Hugo suffered some trauma of his 2 front legs, which resulted in his in the traumatic removal of a number of his whatever the equivalent of his fingers are, phalanges, digits, on both front legs. He also lost his left eye and had some chest contusions, but he survived. And we didn't actually. I didn't actually analyse the results of the DCE that we did on Hugo because I didn't want to see them really. But Hugo was actually made famous, and his survival not only made it on not one news program but 2 news programs, and they interviewed the family as well. He's not as mobile, but he still tends to get around okay. So that's the end of the talk. Just like to acknowledge my supervisors, Lisa Hall, and co-supervisors, Nick Graves, Alan and Mike, and also the gang at South Australia at Flinders Uni, who were of great assistance when it came to constructing and analysing the DCU. So happy to take questions.
Using this methodology to create what people think they want, are there studies where they then apply that and then studying now they've experienced what they thought they want? Does there a change with experience and exposure?
Trish could probably chime in on this because this is my 2 years ago I'd never heard of a DCE, discrete choice experiment, so I'm still learning lots about it.
It's a hypothesis, doesn't it? That this is, we think this is the best format.
It's used a lot for consumer choices and for patient choices of treatment as well. But I don't know about follow-up studies once the DCE has been conducted.
The surgeons who I work with are actually, they've developed DCE and they're doing it, but now they're doing it as a randomised control trial it's looking at surgeon expectation and patient expectations, and they're administering the DCE to the surgeon and patient with one group and not to the other, but to see if alignment of expectation alters outcome. But as far as I know, it's still being developed as a methodology in this arena. So it's translated across from commercial and business and so on, but really it hasn't been well established I think it's just building momentum in health.
But one of the limitations is that a couple of studies has been shown that people tend to choose what they know also. That's not across the board, but that is a bit of a tendency at times.
So you said they currently did the standard protocol annually, and that was what was preferred in this as well. So places that do good surveillance activity at the moment tend to use standard protocol, but which was a separate attribute to the competency. Competency was a different attribute. As far as I know, I'm not sure about this these days, but most surveillance programs don't have any competency assessments attached to them, as far as I know at this stage. Kaz?
Bill, because there's one thing about what people think they want that's sort of influenced so much by their resources and infrastructure and data linkage and everything else. And so have you also looked at it from the other flip point about what are the barriers at the moment for effective surveillance? Just, we have terrible data linkages and we have real issues with the workforce capacity for surveillance, and so that drives so much about what people do, and there's some jurisdictions are much better set up than others. Have you looked at that side?
So that's not part of the DCE analysis, but a lot of the work I've done has been describing the gaps that currently exist and the barriers that are in place at the moment. And essentially, as I described earlier, there's so much variation between the states and the territories, and just the fact that there are people out there doing surveillance who've never been educated or taught how to do it. Because the question was if they ever received any training in surveillance, and more than 50% said no. So that's just, and so I'm assuming that means people are given a slip of paper with a questionnaire, and they go out and try and put it in the best they can. That makes up their surveillance. So the core work that I did with those interviews also looked at other characteristics of surveillance programs and what triggers them, and which is really interesting aspect to the work as well. But there are lots of barriers, and that's not even heading down the political barriers between the states and the jurisdictions and the bureaucracies there. Trish?
Just out of interest, did you include sort of the almost like the end user or the people who you're surveying, so the clinicians who are caring for the patients who are being surveyed and how acceptable all this is? Because I know sometimes there's a little bit of a disconnect between the people doing the surveillance and then the people who are actually caring for the patient, and what they want might be completely different.
Yeah, no, we didn't. At the outset, we were also going to try and include hospital executives and CEOs, but we also did consider, for example, surgeons or physicians. The reason we didn't include CEOs and executive staff was because the language that we had to use in the experiment was really specific to people who know surveillance, and we were just wary if we dumbed it down too much, it wouldn't be appropriate for any group. The reason we didn't include surgeons, apart from practicality, also and numbers, was because when it comes to implementation, generally speaking, it's infection control teams who are the ones who are going to drive, who are going to own and drive the implementation. So a lot of implementation is around about an acceptable program, and so we were keen to get their opinions and understand what they wanted to shape a program that would be acceptable. Having said that, if a program was, in the development, which it's not at the moment, I think that those clinicians would need to be consulted as to so they could have a say. Kirsty?
I was struck by your comment about people choose what they know, and I'm reflecting on in the days when we were promoting electronic approval systems, there were surveys going around with people saying, we don't think we need this. And then when you ask the question, have you ever seen one or have you ever used one, the answer was no.
Yeah.
And that it takes courage to actually imagine something you haven't seen and think about whether it would be useful. So I wonder whether you've broken down questions around like the financial penalty question, for example, between those who've actually experienced it and those who haven't, because I think that would be really powerful. But the ones who've experienced it, their opinion to me would matter more than those who are just imagining something airy-fairy that they don't know.
No, we haven't done that subgroup analysis. We've only, not by jurisdiction, and I thinking the numbers possibly wouldn't be big enough to show us too much. Because we did try to do some subgroup analysis, but the numbers weren't on other areas, but the numbers just weren't big enough. We thought we might see some more differences. Well, we did see a difference with the accuracy of the data. I think that was the only significant difference we found when we did that subgroup analysis. Kaz?
Can I have any thoughts how this can interface with AMS? Because it's been sort of an interesting process over the last, especially with the NAPS, where you see prescribing for surgical infections, and with the SNAPs, where actually a decent number of pharmacists will be actually undertaking essentially hospital-acquired infections surveillance. Which is a new workforce which would essentially be a new workforce capacity for a national surveillance program. Have you thought?
Not for my PhD. Not trying to just get this thing out of the way and done with.
No, I'm asking as a program manager. Because it is interesting, isn't it? Because we have limited resources, and there could be something done well across.
Yeah. Look, I think that's down the track. I think there are just some really basic things that need to be done first in Australia. Clearly, there are people doing surveillance who are doing it for the reasons they don't know why they're doing it. They're just ticking boxes, I think, probably to meet accreditation standards. National standards say that you must do some sort of surveillance, so they think, okay, I'll do this, tick that box, we're accredited. When they're not doing anything with the data, they're not reporting it, they're not risk adjusting it, then I think there's some really fundamental issues that need to be addressed before we can, really take it any further.
I think there has been progress in terms of training. I think Witness has a range of training modules for surgical science patient worker. Another commission also has some training modules, and the commission training modules have been taken up very enthusiastic. I think they've had literally 25,000 people use them or something. International.
Yeah. And I think some of the states have really well-established programs and they do quite well, but not everybody is at that stage. Okay.
Let's just go back to the methodology for the discrete choice experiment. I mean, how you presumably don't compare all possible options because that would be an enormous.
Yes.
So how do you choose which options to compare directly to each other?
Yeah. So I think the options that can generate it are your attributes multiplied by all your levels, and I think mine had somewhere potentially 1,200 potential choice questions that could have been generated. And so that's why I went to Flinders University in South Australia and spent several days there with the experts there. And the exact term escapes me now, but through a number of analysis, there's a program called NGene, and it continues to, it's almost like bootstrapping the data, I think, and what it produces is a choice set. So I had 24 questions and split them up into 2 blocks and then randomised each of the participants into one of the 2 blocks. And so 24 choice questions are thought to be representative of all the choice questions.
So it's
like a sample. So it's the program will provide you with a number of choice questions, which it says it's a representative, and you get a scale of how representative it is, which you then use. And so those choice questions were split into 2 different blocks, and participants were randomised into each of those blocks. Okay, thanks everybody. I'll finish it there. Yeah.
Is that similar to, I think I looked up the webpage and what's written down.
Yeah, just
I'm trying to figure out my PhD as well. I'm trying to figure out how to word it so it doesn't sound like I've got it.
Summarising a few sentences,
Yeah, I'll try and get that to you today.
Yeah, that'd be great. Thanks.
And I guess for future
Yeah. Yeah, I think it stopped, yes.
Sort of prejudging.
Yes.
I guess I can take my time for names out.
Okay, I've got bookings for March. I think there's a space in April. So I'll put you down for May. Yes, great. Okay. I'll get closer to the time. Yeah, you'll commit to it. That's great.